thank you all very much for joining again this session of the Norton Infectious Diseases Institute and the Kentucky Infection Prevention Training Center project on weekly grand rounds. So we had gotten so many requests from participants about antimicrobial stewardship and all of the overlap that we have with microbiology and pharmacy and infection control. So we're grateful to Dr. Ashley Wilde and Dr. Matthew Song providing us in an overview of what antimicrobial stewardship looks like now in the COVID-19 era. So Ashley, let me turn it over to you, and thanks very much.
And thank you for that introduction. So this presentation is actually an encore presentation from one that we gave at the Kentucky Society of Health System Pharmacists earlier this fall. And it was actually Felicia's presentation a couple of weeks ago when she was talking about infection prevention practices in COVID-19 that made me think, well, you know, we've got some data related to antimicrobial stewardship practices and how those were impacted by COVID-19 and kind of where we're at coming out of the true pandemic crisis. So I thought it would be a good presentation for us to revisit here, since the information is broadly applicable to audiences even beyond those of pharmacists. So our objectives for this presentation is, by completion of this presentation, you should be able to describe the impact of COVID-19 on antimicrobial resistance and antimicrobial stewardship practices. And then I'm going to turn it over to Matt, who's going to go over some presentation to enable you to identify opportunities for antibiotic deprescribing in patients with COVID-19. So right off the bat, COVID-19 was the worst pandemic in modern era, and I hope we never have to live through something like that again. But everybody has their own COVID-19 story now, right? Everybody can tell like what happened, what they do during the pandemic, how was their work and their life impacted. But universally across the board in healthcare, antimicrobial stewardship programs were dramatically impacted by COVID-19. We got pulled from a lot of day-to-day activities and reoriented towards COVID-19. And the question is like, well, why were antimicrobial stewardship programs impacted more? Because if you think about it, the core of antimicrobial stewardship is to prevent resistance. We focus on long-term endpoints like the development of multi-drug resistant bacteria. And when COVID hit, we weren't thinking about like, well, let's use narrow spectrum antivirals, or let's make sure we don't prevent the resistance. And, you know, we did have some issues with monoclonal antibody mutations and things like that. But really, stewardship programs are designed to look at the big picture and long-term care and not necessarily treating patients. And in the pandemic, it was all about identification and isolation and then supportive care or whatever treatments we could get, and not necessarily thinking about those resistance in the long run. But partly the reason why we were able to quickly adapt to that is that several core antimicrobial stewardship activities are actually adaptable to COVID-19. And so I listed some of these core stewardship activities, partly because it's important to reiterate what are the main tools that we have to perform antimicrobial stewardship. So the first one being prospective audit and feedback. This is reviewing patients to make sure that the treatments that they are receiving are guideline concordant. And once we did have guidelines for COVID-19, that was something that could be easily adapted to make sure patients were getting the right treatments or the right anti-inflammatory meds. But for the truth of the matter is, everybody started out roughly on the same knowledge level as everybody else. People who do antimicrobial stewardship activities didn't have any advanced training or information in COVID-19. Everybody started the pandemic at the same knowledge level. So this is an activity that could be broadly adopted across anybody who's looking to optimize clinical therapy. Stewardship programs often employ formulary restrictions or pre-authorization, where we restrict certain antimicrobials, which we did a lot in COVID-19, especially when we had shortages of therapies or even shortages of supportive therapies. So we often ran into drug situations where we didn't have enough to go around. And if we needed to really hone in with our doctors on who could get which therapy and at what time, that's an activity that we had a lot of experience with stewardship. With stewardship, we often do antibiotic timeouts to help re-review patients' appropriateness of therapy after a certain amount of time. And timeouts in COVID-19 also became fairly popular once we had our test results back, whether it was a true positive, maybe a false positive or false negative. Performing that timeout to be able to reassess and say, okay, is it COVID-19? If it's not COVID-19, what switch do we need to make in therapy? So a lot of stewardship personnel also perform those activities. But I think the real reason why stewardship program personnel got pulled in COVID-19 was because we have a lot of experience engaging with the clinical microbiology lab as well as infection prevention and helping clinicians interpret test results and conveying what the results might mean in the clinical context, looking for epidemiologic trends and working with our infection prevention partners to be able to say, okay, who needs to be treated, what sort of isolation status we may be, do we think this person might be still contagious? It was really a team effort. And compared to other personnel and those who had done antimicrobial stewardship had close working relationships with both of those departments. And last but not least, developing guidelines on how we treat patients. As I mentioned before, nobody had any advanced training on COVID-19. So it's not like I can say, well, let me just fall back on my many years of experience on how to treat patients with COVID-19. But we were obviously able to help develop local guidelines based off of what we were seeing, as well as educate people on those guidelines as time and time again, new evidence came out. I will say that about a few months into the pandemic, I gave a presentation on bugs and drugs, something that I do once a year for all of our pharmacy students. And man, was it really good to be talking about things that I actually knew about, because for so long, all I had been talking about was COVID and people expected us to know the answer. And so to be able to read the literature and with very low quality of evidence or non-peer reviewed evidence, try to sort through all of that took a great amount of time. So managing patients prospectively, reviewing them once we had test results, engaging with the different departments, and then trying to educate and re-educate everybody as things change so fast. It shifted so much of our antimicrobial stewardship personnel towards COVID-19. But it begs the question really, like if everybody was being admitted for viral infections, do we really even need antimicrobial stewardship? Because, we talked about stewardship being the prevention of resistance, and typically stewardship programs focus on bacterial resistance. And again, if everybody had viral COVID-19, do we really need antimicrobial stewardship? And the answer is, of course, yes, because what we saw with COVID-19 is that we had high rates of antibiotic prescribing despite very low rates of bacterial co-infection. And so I just took 3 studies. There's many more out there describing how often antibiotics were prescribed empirically in patients who presented with COVID-19. So this is not people who have been in the hospital with ARDS and been on a ventilator for weeks. We gave them a bunch of immunosuppressants and they go on to develop a secondary bacterial infection. These are patients who have shortness of breath, have cough, have fever. They come to our hospital because they need supportive care. And how often are we starting them on antibiotics, despite the fact that we either knew or had a high likelihood that this was going to be COVID-19? So in an early study from Michigan hospitals across a survey across the state, 56.6% of patients who were admitted for COVID-19 received antibiotics, despite only 3.5% had a confirmed community onset bacterial infection. In New York City, where they got hit really hard, really fast with the pandemic, 70% of patients were started on empiric antibiotics, and they only saw 3 to 8% of their patients had a confirmed secondary bacterial infection upon admission. And then one study that was published out of an ICU in London, 100% of them were started on empiric antibiotics, despite only 6% of them had a confirmed community onset bacterial infection. I think this is really important to highlight because antibiotics are often started just in case, just to be safe. And that idea of it's the safe thing to do to start them on antibiotics can be really challenging to balance with what are the long-term consequences of unchecked empiric antibiotics. Since oftentimes people are thinking about the short-term consequences. And again, London ICU study, the fact that they were critically ill may persuade providers to start antibiotics more often. But one of the analogies that my counterpart here in Norton likes to do is to describe empiric antibiotics or unnecessary antibiotics like they were something like thrombolytics, so something like TPA that we use to break up clots. Imagine that if 100% of patients who were admitted with altered mental status were given a thrombolytic, just in case they had an ischemic stroke, right? So just in case this altered mental status wasn't due to a dehydration or wasn't even due to a hemorrhagic stroke, like just in case it was ischemic, let's give them a blood thinner. And you would be stopped so fast if you just started prescribing thrombolytics like that, because the immediate consequences would be seen and we would determine that that was not in fact a safe practice. But the immediacy of those adverse events are much more easy to balance with, like, well, what are the efforts and at what length should we go to determine that they in fact have an ischemic stroke? But with antibiotics, it's so hard to put that in context since we don't see the consequences of unintended or empiric antibiotics till much later. But maybe we didn't need antibiotic stewardship despite the high rates of prescribing, because there were actually some very good things that came out of COVID-19 when it comes to the fight against antimicrobial resistance. So hand hygiene became really popular during COVID-19, right? You couldn't find hand sanitizer like anywhere. Distilleries here in Kentucky started making hand sanitizer because there was such a high demand for people to wash their hands and keep their hands clean, which is obviously, for those of you who work in infection prevention, is so instrumental at stopping the spread of antimicrobial resistance. During pandemic, we also limited visitors in a lot of hospitals or care settings, which if you had a loved one who was admitted to the hospital, this could be especially tragic because you weren't able to be with them or only a limited number of them could be there. But what we did see was just less people's going between cafeterias or common areas and patients. And we can enforce hand hygiene and isolation precautions in employees much better than we often can with patients who may not understand how to don and doff PPE appropriately. So having less people around can definitely lessen the spread of antimicrobial resistance. We can also enforce social distancing. So it became very faux pas to be anywhere near other people, especially in indoor settings, which can lead to less resistant spreading. And we also saw an uptick in telemedicine fairly quickly. I mean, we had the technology, ahead of it, but when people didn't want to go into a waiting room and sit with other sick people, that obviously lessens the burden of being able to spread antibiotic-resistant bacteria. Now, I've already mentioned some of the bad things. So, we had some good come from the pandemic, but we also had some bad. As I already mentioned before, diverted stewardship resources. We had widespread antimicrobial prescribing. One of the bad things too, especially early in the pandemic, was a lack of COVID-19 tests. And so some of that context that I brought might be now even in the back of our mind about, it used to take us a lot longer to find out if somebody had COVID-19. Now we've got rapid tests all over the place, which is good. But for a while, we didn't have that confirmatory test. It often took days to get the results. What was bad as well is we often had a lot of critically ill patients. Thankfully, that's not the landscape that we are seeing nowadays. But if you remember earlier, we had a lot of patients who presented with very severe infections. And that does drive providers more often to use empiric antibiotics because that margin of error, if it was in fact having some element of bacterial infection, definitely don't want to take that risk. And last but not least, there was a lack of PPE. We had to reuse PPE. Oftentimes organizations didn't have enough isolation or PPE resources for COVID-19. And so they made these tough decisions to say, well, let's not isolate patients or use contact isolation for things like MRSA in order to divert some of that PPE resource towards protecting our employees that were taking care of patients with COVID-19. So I presented some of the good, I presented some of the bad. And the big question was, well, who's going to win out? Is it good? Is it bad? Did the elbow bumps and the masks and all of that really stop the spread of antimicrobial resistance? Or because of this perfect storm with widespread antibiotics and just critically ill patients, did that end up increasing the spread of AMR? And unfortunately, if you were following the titles of my slides, I presented the good, the bad, and now I have the ugly. In 2022, the CDC had released a special report that described the impact of COVID-19 on antimicrobial resistance. And what they said is that COVID-19 really was the perfect storm. So they saw a 15% increase in antimicrobial resistant infections and deaths in 2020 compared to the year prior. And overall, they cited about 80% of patients that were hospitalized from COVID-19 early in the pandemic had received an antibiotic. And so over the years, we've worked so hard to try to contain and reduce the spread and the development of antimicrobial resistance that COVID-19 just set us back really far. And so if you want to know specifically about what happened, this is an infection preventionist's worst nightmare. So the available data, which shows here between 2019 to 2020, 78% increase in carbapenem-resistant Acinetobacter, 32% increase in ESBL producing Enterobacterales, VRE, drug-resistant Pseudomonas, MRSA, all up. We even saw higher rates of some of our resistant fungus, including Candida auris. and carbapenem-resistant Enterobacterales as well, all of them much higher in 2020 compared to 2019. So there is some light at the end of the tunnel. We do have faster COVID-19 tests, as I mentioned. We do have COVID vaccines and therapeutics, which is making the severity of illness much less. But one of the important things is that there is a renewed interest in infectious diseases, both professionally as well as in the public. I think people really start to understand what communicable diseases really means to society. And so a part of this as well was the strengthening HAI and AR program is able to support a statewide stewardship program for Kentucky. And so we have our information about the Kentucky Antimicrobial Stewardship Innovation Consortium listed here. If you want to learn more about antimicrobial resistance and antimicrobial stewardship and all the support and education that we can offer from KSIC, by all means, you can scan this QR code or visit the website down below or email any of us. We're happy to help provide any sort of resources and support for organizations that are looking to help with antimicrobial stewardship and the fight against this antimicrobial resistance. So with that, I will turn it over to my colleague, Matt, to talk about opportunities for stewardship in patients with COVID-19.
Okay, does everybody see my screen correctly? Okay, great. Yeah, so for my portion of this presentation today, I'll be speaking about some of our opportunities to perform antimicrobial stewardship in COVID-19. And for this portion, I'm going to limit that to two common clinical scenarios. The first one's going to be co-infection, and that's going to be the situation where a patient initially presents with COVID-19, but there's also a suspected concomitant bacterial infection. And then the second scenario that I'll describe will be the case of secondary infection. And so that's going to be the situation where the patient has been admitted in the hospital for a prolonged period of time already, and then subsequently develops a secondary infection. So to begin with this, what I'd like to do is advance my slide. So to begin with this, what I'd like to do is just present a case of a real patient who actually presented to one of our adult hospitals early in the pandemic, to just highlight some of our opportunities for antimicrobial stewardship. And so this was a 47-year-old female who presented to the emergency department in summer of 2020 with cough, shortness of air, fever, body aches, for a couple of days. In our emergency department, she had an objective fever of 103.1. She was tachycardic. She was hypoxic, requiring supplemental oxygenation. But otherwise, her rest of her vitals were normal, and then she also did not have a leukocytosis. A chest X-ray was obtained in the ED that demonstrated bilateral infiltrates suggesting a multifocal pneumonia, and additionally a chest CT was also obtained, which showed bilateral ground glass opacities with some reactive adenopathy that was deemed to be of high likelihood for COVID-19 by the radiologist. We swabbed the patient for COVID-19, and then we started her on empiric antibiotics with ceftriaxone and zithromycin, which is a common empiric regimen used for community-acquired pneumonia. The patient was subsequently admitted to the hospital, but the following day, the MP swab returned positive for SARS-CoV-2. And then we also had a procalcitonin that was on the lower end at 0.11 nanograms per ml. And so really this question becomes, do we have an opportunity to perform some antimicrobial stewardship here? And I think one of the first things that we want to consider when thinking about these types of cases is how often does it actually become a problem? And really just to reiterate some of the information that Ashley presented in her portion of the presentation, that bacterial co-infection rate is rather low. So it's under 10%, but if you look at some various studies, you see it as low as 3% in some instances. And so for all my tech savvy people in the audience here, I've also included a QR code that you can use with your phone. It'll direct you to a website that actually has a pretty interesting interface that allows you to stratify the reported prevalences of co-infection and also secondary infection based on like age, gender, and severity of illness. So again, the actual concomitant prevalence is pretty low, but then additionally, we also have guidelines from the National Institute of Health on the management of COVID-19 patients, and their recommendation is that they recommend against routine empiric broad spectrum antibiotics with severe or critical COVID-19. They do, however, go on to say that there are some criteria that might indicate a patient more likely to have a bacterial infection and where antibiotics may be more, or at least should be considered. And in those situations, they note the lobar infiltrate on a chest X-ray or leukocytosis. And so these are some findings that may be more specific for a bacterial infection. in patients with an elevated serum lactate level or those with shock. And so this is really mimicking the sepsis approach, the idea that acutely the patient is so ill and we just wanted to minimize the chance that we're wrong. And so we would empirically cover in those situations. And then lastly, any microbiological data that would help make the diagnosis for a bacterial infection, such as a positive sputum culture or something like that. One thing that is missing from the National Institute of Health guideline that I think is pretty useful, something that we've used a lot in our practice and then others have reported on, is the role of a procalcitonin. Just to quickly review, procalcitonin, it's a biomarker that is typically elevated in bacterial infections and not in viral infections. There are limitations associated with the use, particularly in our COVID-19 patients. There have been studies that have demonstrated essentially false positives in patients who were found to not have a bacterial infection but only have COVID-19. But its role is probably better in helping to stop antibiotics than it is to start antibiotics. And that can be mainly focused on its high negative predictive value. And so in one study that had about 2,500 patients, they looked at the role of a low procalcitonin, basically excluding bacterial infection and using two different thresholds. The most commonly threshold used in practice are either 0.25 or 0.5. And you can see from my slide here that it's a pretty high negative predictive value. And so in the context where you have a patient who presents ill, you have the alternative explanation with COVID-19, you have the epidemiological data saying that the rates of co-infection are low. And then lastly, you have this biomarker that can help provide additional information suggesting that there is no secondary infection. You know, this really becomes a ripe situation in which we can make a recommendation to stop antibiotics, hopefully. But again, just to reiterate, it's procalcitonin. It's not recommended to start those antibiotics, and that's related to some of its false positive and false negative issues. But in the situation where the patient's already been started on antibiotics, it can be particularly useful. And one last thing before I get back to the case, though, is I just want to emphasize that when we think about COVID-19, there was always a distinction between the ones that went to the floor and the ones that went to the ICU. The ones that went to the floor, they were ill, but they weren't really, I would say, different from what we'd seen in the past. But the ones that went to the ICU, I think, were a completely new patient population. But even with that level of severity of illness, there have been just proposed antimicrobial stewardship focused approaches to using antimicrobials. And so for this one review article by Dwell and colleagues, they specifically focused on patients with COVID-19 who went to the ICU. And you can see that even in those patients, they're recommending that we should look for shock or other radiographic imaging consistent with a bacterial infection before making the decision to proceed with antimicrobial therapy. So this is really consistent, I would say, with the NIH recommendations. But I think it's good to see that. And then really when in the absence of one of these findings, they're recommending that we proceed with monitoring these patients off antibiotics, using a watchful waiting strategy, culturing them, maybe using some serial procalcitonins. The idea that if a patient has an untreated bacterial infection, you should see that procalcitonin continuously rise. Or the use of any other rapid diagnostics, such as molecular identification technology. But to provide a little bit of happy information, let's go back to our patient. And so that patient who was admitted to the hospital, but then returned positive with COVID-2 or SARS-CoV-2 and then a low procalcitonin, our antimicrobial stewardship team actually did make a recommendation to stop the antibiotics on day 2, which was accepted by the team. The patient went on to have a 7-day hospitalization and then was discharged after 7 days. And when I made these slides a couple of weeks ago, it was roughly about 2 years since that patient was hospitalized. And I found that since then, that patient had no recorded infection-related readmission. So that makes me feel good that we didn't make a bad recommendation in withholding antibiotics in someone who maybe had needed them. But then also, there was no recorded C. difficile infection or subsequent infection due to any drug-resistant bacteria that might have occurred in the outpatient setting either. And I think that's important to highlight that we're really getting that negative outcome, or rather, the negative of the bad outcome. And so that is, of course, what we're always trying to prevent with antimicrobial stewardship. And I wish I could continue with this happy tone with antimicrobial stewardship, but I think I'm going to revert back to our old tricks and try to highlight some of the dangers when it comes to overuse or unnecessary overuse of antibiotics. And that's going to be related to the second clinical scenario of COVID-19 with secondary infection. And so just to highlight those who've had experience with COVID-19 patients who went to the ICU, I'm sure all of y'all remember how sick they were, but just to give everybody else a little bit of context, these patients, they came to the ICU and they stayed longer, more than other patient populations. They stayed on the vent longer. They required more intensive supportive care, including high levels of mechanical ventilation, but then also in some situations, ECMO. Specifically in this patient here, we had a patient who was transferred to us because of ECMO. And so ECMO is an extracorporeal membrane oxygenation. Essentially, the idea is that the lungs become so damaged that efficient gas blood exchange cannot occur. And so we actually just take your blood outside of your body and oxygenate it externally and then put it back in your body. Not everybody can do this, but we are fortunate to have this service at our place. And so this patient, hospitalized for 3 weeks at an outside hospital, wasn't doing well, transferred to us to get this advanced supportive care. Throughout this entire first month of hospitalization with us, this patient had 0 antibiotic-free days. So that means every single day this patient was on at least 1 antibiotic. That included 19 days of cefepime and 14 days of meropenem. And this patient did appear to have a secondary infection, so antibiotics were warranted. But when we actually looked at our culture data, we had a bronchoalveolar lavage, so essentially a lower respiratory tract sampling that grew MRSA and Enterobacter cloacae. The patient received vancomycin for MRSA, if anybody was wondering, but for the Enterobacter cloacae, we cultured it several times and it was always cefepime susceptible. And despite that, we used 2 weeks of meropenem in that first month, which in general, we'd like to preserve that for Enterobacter cloacae that is cefepime non-susceptible. So because of that, subsequently, what happened was that this patient actually went on to develop a further secondary infection with a carbapenem-resistant Citrobacter forandii. And so in retrospect, it really makes you wonder whether or not we had opportunities to kind of peel back some of that meropenem because we were left with this highly resistant organism in this very critically ill patient. And so when we're thinking about what are some of the things we can do proactively to try to prevent this, because like Ashley said, when it comes to antimicrobial resistance, you really don't know you have a problem until it's too late. And so really all of your opportunity to try to fix antimicrobial resistance occurs before it actually happens. And so some of these strategies that we recommend in these particular situations is just the same ones we've always recommended, but applied in a COVID-19 situation, I'd like to discuss further. And so obtaining appropriate cultures, and that's going to be before you start antibiotics and then before you escalate antibiotics, getting those cultures so that they're not, so that the sensitivity is not decreased with the administration of antibiotics prior and basically affecting your ability to isolate an organism. And then when you get those cultures back, using de-escalation strategies, and you can use them both in situations where you identify an organism or in situations where you don't identify an organism. And so in positive cultures, trying to use the most narrow targeted therapy to that organism. But then more difficultly in negative cultures, we often have a lot of pushback because there isn't a clear role. But here I think is a good strategy that's been used in several different places before is emphasizing the pertinent negatives. And so if you don't identify any MRSA or you don't identify any Pseudomonas, that should be able to give you opportunities to stop vancomycin or broader spectrum gram-negative beta-lactams or other agents. I will note that it is particularly difficult in the critically ill. You don't want to overstep. You want to kind of take it easy on these patients. And an approach that I've used in the past that has been well received when providing recommendations is suggesting a stepwise approach. And essentially, that's where you stop one antibiotic now, see how the patient does, and then stop the other antibiotic or de-escalate the antibiotic and then see how they do. Additional strategies that I've used have been adding stop dates at the beginning of the initiation of antibiotics. And so this is particularly pertaining to the long and parent courses that we sometimes see. I think a lot of situations we get to the point where we think we might be able to stop antibiotics, but the patient isn't necessarily doing well. And this becomes somewhat of a, a puzzle, right? Because in a lot of situations, you would extend durations of therapy if they're not clinically doing well. But after a set amount of time, if they're not doing well, it really starts to argue against whether or not the patient has a bacterial infection at all. And so in those situations where a confirmed infection isn't made, I definitely like trying to use stop dates. And then lastly, just the term that I think I've encountered a lot of pushback when it comes to making recommendations to stop antibiotics. And so somewhat of a strategy that I use is I try to console the concerns in that strategy and use the term monitoring off antibiotics, the idea that we're still keeping an eye on these patients and ready to start antibiotics if needed. And whether or not you believe that the COVID-19 is over, I really don't want to get into the logistics of all that, but I think we can all agree that COVID-19 isn't as bad as it used to be. But I think from everything we know now, and then all the other reports of, monkeypox, and then maybe Ebola is on the rise again, we're probably going to see another, widespread pandemic like this. And what I want to do then is just highlight this paper that was put out by the Society of Healthcare Epidemiology of America. And I think this is a good tool that we can look to early on, so we don't make the same mistakes we made in the early parts of the pandemic and basically completely forget about antimicrobial stewardship and then suffer the consequences that Ashley noted earlier in her portion of the presentation. And with that, that concludes my portion. What questions do you guys have?
Thank you, too. This was excellent and an excellent overview and really timely. And I think you tied it very well, both you and Ashley, into the information that we had, not only when Valencia was talking about simulation and education, but everything that we've had in the literature that is really highlighted the challenges that we've had in diagnosing patients during COVID and the problems in trying to forecast bacterial versus viral, and all within the constraint of realizing that patients that are recognized and treated early in normal times have a greater likelihood of a positive outcome when compared to those that are treated late. So that is a challenge in addressing this during COVID. So I love the algorithms that you brought in reminding people, but it's also interesting then, and how do you see this, or what is changing? As you mentioned, Matt, specifically the fact that we're at a different place now with the pandemic. And so should we now be thinking more traditionally in this approach? And what does that mean? And then Ashley, as we're trying to put all this in within the context of stewardship, and I know maybe this takes a crystal ball or a Ouija board to try to figure out, what should be some of the thoughts, but as we are thinking about taking this back to our individual organizations, what's in your mind about using this information at this point in time?
Yeah, I mean, I can just give you my thoughts sort of, and then Matt can add his as well. I think there's two things. Like one, like technology has to be better prepared to be able to handle pandemics the way it used to be. So we used to think about disaster preparedness as like, a small number of people that wouldn't require ongoing and continuous re-education, reinforcement, and adaptability. But I think a lot of people have gone through the pain and exercise of doing it manually when COVID-19 caught us off guard, and having epidemiologic technology, and then also just enhanced laboratory capacity. That's part of what these other like ELC grants are supposed to be able to do, to be able to support things in a faster manner, because we recognize now that you can't just say, well, we don't have any COVID-19 in Louisville, we're only going to test people from China or Turkey, or Italy, when, like those were the only areas that had it. Like we learned our lesson the hard way from that perspective. And then I think when it comes to antimicrobial resistance and antimicrobial stewardship, I think that we need to sort of use our captive audience when it comes to the people who have experienced the direct impact of managing patients that have infections that they don't have anything to treat with. And that's the sort of like the sky is falling, the sky is falling. That's what we talk about a lot of times in antimicrobial stewardship. It's like, well, this person could get a CRE, right? If you give them too many carbapenems, that's going to become resistant. And then where do we go from here? And a lot of people think like, well, that's very unlikely to happen. That's very far off, or that's not going to be my patient. But that idea of things are going to be impacting us in a global health perspective that doesn't necessarily going to be originating from my individual patient, but how am I going to individually contribute to global antimicrobial resistance? So I think it provided much of a wake-up call. And so to be able to reinforce those concepts about like the consequences of unnecessary antibiotics, and how do we get buy-in from people who are immediately remembering that impact of what it was like to take care of these patients when you had nothing to offer, and making sure that you build upon the credibility that we earned during the pandemic to say, like, look at our ability to evaluate literature, apply it in an evidence-based manner. That's what we're trying to do in infectious diseases all the time. I can't tell you how like eye-opening it was to have some of our doctors, who are some of our biggest naysayers about our recommendations, proactively calling us and saying, well, you guys know much more about this than I do. And I'm like, that was actually true pre-pandemic when it came to antimicrobial stewardship. It's like, this is all we think about is the optimal use of antibiotics, and really trying to find those opportunities to make small adjustments in therapy, either on spectrum of therapy or duration of therapy, to make a difference in the long run. And so using those things together to be able to make sure that people aren't totally burnt out about talking about infectious diseases, but have a renewed interest in the fact that this can impact me, right? This can impact me as an individual or my patients, and what I can do to help with that.
Yeah, I mean, for the practice component, I think just, I think that the changes that we take, the lessons learned from here is just applying some of these I guess, judicious strategies. Like, I think part of the emphasis that we saw in the back half of antimicrobial stewardship in COVID is just because of the sheer volume of COVID-19 that we were seeing in hospitals, and the sheer amount of antibiotics where, you know, we really questioned whether or not like we needed to give all those people antibiotics. Because honestly, if you compare it, you know, the approach really isn't that different from any other viral infection, including influenza or any other of the just routinely circulating viruses that don't present as critically ill, but I think the sheer volume was the big difference. And so I think taking these lessons learned and applying it back to what we already knew, and then being prepared for the next, you know, viral pandemic, potentially pandemic pathogen.
Well, and I think, you know, there's been so much work that you all have been doing recently in realizing that everybody's at a different place with stewardship. And, you know, not only was everybody at a different place before COVID, but now that, you know, we're trying to make our way out of many of these surges. Do you have some thoughts? Because I know a lot of the people that we have that are on this call are at different places, you know, some in community hospitals, some at university hospitals, some in clinics, and some in public health. And any kind of thoughts about how do you get started? Just, you know, I know that can be like a 10-day discussion, but maybe just some pearls of wisdom, I guess, as people go back to their organizations and say, now we're kind of hitting the reset button. How do we restart our stewardship approaches?
So I think data-driven action is always the best thing you can do. So for me, in my opinion, if you don't have any data, that's really the first place you'd like to start, is get some data to figure out exactly where you need to do stuff. But if you don't have that, and it's very difficult to get that, I think looking at your frontline caregivers, and so your physicians, your advanced practice practitioners, your pharmacists, your nurses, asking them, hey, what are you saying? You know, there's always like a handful of common opportunities. You can specifically, I would start open-ended and then ask them, how's this practice regarding this particular thing? And then after, you know, maybe identifying opportunities that way, focusing on one or two and then trying to build those. I will emphasize that, you know, as Ashley mentioned, we have developed the statewide stewardship program, CASIC, and we are readily able and wanting to help people in essentially getting started with their stewardship. But for a lot of people who are already started on their stewardship path, helping them expand or really just being somebody there to kind of just bounce ideas off. I think that's going to be a good role for CASIC for a lot of places where they're a little bit more limited in terms of just having fresh ideas and stuff.
Yeah. And the other thing I'll add to what Matt said is that everybody has a role to play in antimicrobial stewardship. So don't think that if you have a stewardship program at your organization, they're the ones that do stewardship, because everybody can do something. Everybody who's touching patients, talking to family members, the bedside nurse, even if they don't have specific training in infectious diseases, can prompt the questions to the providers. Is this antibiotic still needed? Right? They may not even know what the IDSA guidelines are for recommended duration of therapies. They may not know which antibiotic is the right one for their patient, but they can still prompt that to just make sure everybody's thinking about it. Everybody's aware of the judicious use of antibiotics. And so from the perspective of my advice is really don't think well, I got a guy, right? They're on it. They can just do everything, because those moments to identify or counsel on the best and most appropriate use of antibiotics, you never know where that's going to be. And I mentioned technology can help us improve the impact of people with infectious diseases training to reach areas that they may not have without such technologies, but you can't do everything. And I think that idea of you've got a team and that's the only people who do stewardship is definitely not the case, because we have to think about it constantly, and everybody can make their contributions in whatever capacity that either their license or their training allows. But just figuring out a way to make sure people are thinking about it and recognizing the importance of that will go a long way. And I hope people don't try to mentally block it out. I don't want to talk about infectious diseases anymore. I get that people have a lot of burnout when it comes to COVID-19, but this is something that is just going to, it's going to be with us for a long time.
I think, your point is well taken in that this is a role for everybody. That traditionally, we think about the antibiotic issues or the antimicrobial issue is firmly in the area of the pharmacists who understand the drugs and then can help the ordering clinicians make some of the right decisions. But then we think about other personnel, for example, in nursing, if you have poor practice in obtaining a blood culture, then you provide poor results that you will use, the clinician will use upon which to base the treatment decisions. We talk about environmental services personnel. They really are in charge of antimicrobial stewardship of the germicides, the disinfectants that are used in the organization to match then what is used to combat then the most common pathogens that are seen in an organization. So when you think about the components of stewardship, it's a team sport, and it's really engaging every person in that, and then finding it within the organization where, what's the capacity to look at this problem. And just when the gun goes off and the track meet starts, not everybody runs the same journey and at the same speed, but we hope everybody crosses the finish line at some point. So pacing yourself and then getting information from experts and then trying to, figure out, that seems to be kind of the biggest challenge that everybody needs to be. You need to be, I guess, somewhat satisfied with your starting point and then build from there.
Yeah, and Flinch asked a good question in the chat. She said, do you have any suggestions on how a patient's family members can be engaged in antimicrobial stewardship initiatives? And that's another big one that, again, it doesn't take really advanced training to understand the basic concepts to be able to educate the public or educate family members on antimicrobial stewardship. So one of the important things is, antibiotics do not treat viruses, right? So the basic concept of what is the difference between a virus and a bacteria, you don't have to necessarily get out there and draw some cell structures or anything like that, but emphasizing that those are two different classes of microbes and that antibiotics do not treat viruses. And then that the symptoms can very much mimic each other. I think the other thing that's important to do to engage family members or patients about antimicrobial stewardship is that the perception that antibiotics are only beneficial, and that if a doctor is not prescribing you antibiotics, that means they are potentially harming you. So helping sure people understand that antibiotics can cause harm. And that when we use them inappropriately, it can actually hurt patients. And so somebody whose patient or somebody's not being a good doctor because he's not giving them what they want, be able to speak to the fact that this is actually better for the patient, and that they only see antibiotics as something that's pure positive without the risks that they see. So we're getting next month, there'll be Antibiotic Awareness Week, and there's a lot of great public information about appropriate use of antibiotics. Antibiotics are listed from a drug category perspective as the #1 reason for emergency department adverse event visits. And so this idea of, allergic reactions or severe tendinitis, whatever the class may be, you don't necessarily have to speak to which drugs cause which side effects, but they're not without harm. So emphasizing that, when they don't work and what situations it's better not to use them can go a long way of just helping people understand.
This was excellent. I love this. I think the topic is so timely and really brings in the importance of looking at infection prevention and control as a very broad set of players and responsibilities and actions. And it really should prompt in our whole components of broadening our team. So thank you very much for this. Thank you for all the participants. Thank you all for entering information in the survey so we can provide that back then to CDC as requested. And we'll try to use the same method at the beginning of each of the grand round sessions, so we can then make sure that we're continuing to focus on the audience and make sure our topics are relevant and of interest. So thanks very much, everyone. We will see you back then, same time at noon next Wednesday.